Hey everybody, how's it going? This is Liz Gregg. I'm very excited today to have Global Institute Medicine Grand Rounds and my oldest friend in global health, probably, Dr. Ross Boyce. Um, I am coming to you today from Panama, where I'm at a military and biosurveillance conference, actually, which I also had invited Dr. Boyce to, not before realizing they were on the exact same day. So now the department gets the benefit of my intrinsic disorganization to hear him speak to us. But Global Institute at UM does the sort of broad-based coverage of global health, but focuses specifically on disasters and climate and health, under which malaria most certainly falls in my definition. So excited to bring him here for everybody, and I'll let Dr. Kaku introduce him more formally.
Thank you, Dr. Gregg. Yes, so I have the pleasure of introducing Dr. Boyce today. Dr. Ross Boyce is an associate professor in the Division of Infectious Diseases and Department of Epidemiology at the University of North Carolina at Chapel Hill. Following graduation from Davidson College in 2001, Dr. Boyce was commissioned as an infantry officer in the United States Army. He completed 2 deployments to Iraq, where he served in a variety of leadership positions, including reconnaissance platoon leader, operations officer, and civil military officer. For his service, Dr. Boyce was awarded 3 Bronze Star medals, including one with the Valor Device for heroism in combat. Upon leaving the military, Dr. Boyce attended medical school at UNC. Between his 3rd and 4th years, he completed a master's degree in public health at the London School of Hygiene and Tropical Medicine. Dr. Boyce then completed his internal medicine residency at Massachusetts General Hospital in Boston. He returned to UNC in 2015 to pursue his infectious diseases fellowship, joining the faculty in 2019. Dr. Boyce's international research focuses on the spatial and clinical epidemiology of malaria in Uganda, particularly in rural, underserved communities, with an interest in novel methods of prevention and control. He is the principal investigator on multiple studies, including 2 phase 3 clinical trials funded by the National Institutes of Allergy and Infectious Diseases. His trial of permethrin treated baby rats was recently published in the New England Journal of Medicine. More locally, Dr. Boyce leads a multidisciplinary research collaboration, the Vector-Borne Disease Epidemiology, Ecology, and Response, also known as VEER Hub, focused on issues of tick and mosquito-borne diseases endemic to North Carolina. He is a site PI of the CDC-funded Southeastern Center of Excellence in Vector-Borne Diseases. In this role, he works with partners across the state, including North Carolina State University, Appalachian State University, and Western Carolina University, as well as the North Carolina Division of Public Health and Fort Bragg. Please join me in welcoming Dr. Boyce.
Great. Well, thanks for having me, inviting me. I do wish I could have been there today. I was just in DC the last couple of days, so we've been a bit much on the travel side, but really excited to talk to you about this. There's a lot here, and I think a lot coming down the line that is going to continue to develop, and hopefully this moves forward. So I'm going to get started. Sort of the standard declarations. This is the funding that I currently have.
Dr. Boyce, I'm sorry. Can you put up your slides? We lost them.
Huh, they're still
We can see them.
showing.
I can see them, Laura.
Oh, apologies.
Okay, glad to know I'm not going crazy. Um, so here's what I want to talk about today. I'm going to talk about the specific trial, um, how we did it, why we did it, what it turned out, what the future directions are, and talk a little bit about my reflections on some of the success. Hopefully not my reflections, as I can see the spelling went well there, but just for those who are sort of still in the trainee phase of things. And this is a picture of our site where we work, if you're curious. So as you may or may not know, malaria still remains a massive burden globally, particularly for young children, and largely in sub-Saharan Africa, where almost 94% of the cases and 95% of the deaths still occur, unfortunately. And you can see that there's specifically some very high burden countries. Some of it's related to size and population, like Congo and Nigeria, but some of it, for example, Uganda, where I work, there's probably a disproportionate burden based on the size and population. Unfortunately, as you may be aware, there has been some backsliding, particularly in these high transmission areas. Some of that I'll talk about. Some of it is related to policies and funding, but there's also some biological mechanisms that may underlie some of that. So malaria in Uganda, as I said, remains a critical issue. Most of it is falciparum malaria, which of course has the greatest propensity to cause severe malaria and results in death. You can see sort of the distribution of where the transmission intensity is. Uganda does have an issue that they've recognized, and they have a new effort. But really, the concern is that the hospitalization rate for malaria is much higher than in neighboring countries. And a lot of that may be due to access and getting timely care. So when we were starting this trial, this is really what the current state of affairs for malaria was. Of course, bed nets, and at the time they were largely pyrethroid only. Focal indoor residual spraying, which really was not done on a wide scale. And if you're familiar with this at all, you know that it actually takes quite a bit of logistics to get spraying done. Good diagnostics with these rapid diagnostic tests and IV artesunate and combined therapies for treatment, which at the time were still considered really effective. But there's challenges related to this. And part of the reason for some of this backsliding that we were seeing in Uganda, as well as some of the neighboring countries, are related to resistance to pyrethroids. So pyrethroid, so permethrin, and some of these insecticides really were the first line ever since we moved off of DDT and organophosphates. Pyrethroids, which were originally derived from chrysanthemum flowers, were the first line. But through a mutation in the mosquito, they can develop resistance to the killing effect of pyrethroids. And for example, in much of Uganda, the prevalence of this resistance mutation is probably, I would say saturated is the right word, but if you wanted to put a number on it, probably between 90 and 95% of the malaria vectors carry the resistance to this. And so this means that bed nets still protect when you're under it. Obviously, it creates a physical barrier, but you're not actually killing any of the mosquitoes that land on it. So this is a fancy entomological term that I like to use to pretend like I'm smart, but crepuscular means biting during dawn and dusk hours. And so nature is smart itself, and mosquitoes learned that maybe it doesn't make sense to go into the home when there's a mosquito net in there that might kill them. And so they started doing more and more biting when people come out of the nets in the morning, when you emerge to get up to go to the bathroom or to make breakfast, or when you're hanging out around the house in the evening. And so we're seeing increasing rates of this happening, which makes nets not particularly useful. I mean, they're still useful in the night, but when you have this fringe biting, they're not as effective. Of course, climate change plays a role in this. We've seen introduction of malaria into new areas where it wasn't before, and then largely through things like extreme weather events, flooding, for example. We've seen surges. And then really unfortunately, we've seen resistance to artemisinin therapy start to emerge in Africa, similar to what's happened in Southeast Asia. This is largely delayed clearance. It doesn't necessarily result in treatment failure, but it's often sort of the first sign of not good things to come down the pipeline. So we really focused on the idea of outdoor biting, which I'm going to use as a simpler term. And the idea is, if we wanted to protect against outdoor biting, how would we do that? Because it is a tough challenge. You've got to protect the individual basically in a way that's mobile, that can account for a lot of different environments. And for some things, you also have to be careful about the environmental exposure piece itself and whether or not anything you're going to do would be toxic to the environment as people are moving around. So if you've been to sub-Saharan Africa, you'll notice that these wraps that women use to carry their children are ubiquitous. And I've yet to be in a place where they're not used in some form. The textures, the patterns, textiles themselves can vary, but this is really common. We actually carried our kids this way when they were young. And so in thinking about could we leverage this, it seemed like a natural fit. And the reason for that is one, they're already used. I mean, they're used widely. So there wouldn't be a behavioral change piece required. And we can target young kids who are really the most vulnerable to the worst effects of malaria. It's one thing to make a case to global funders and say, we want to treat every piece of clothing that everyone is going to wear all the time. It's a big ask. I'm not saying it's impossible, but to get that foot in the door, this seemed like a good place to start. So as I mentioned, they're widespread. They're used, at least in Uganda, from about 2 months of age. This varies a little bit. When we've done some exploratory work in DRC, it seems like it's closer to 3 months is when they start to be used. And then they're used to about 2 years of age. And the reason for that is one, children start to be more mobile themselves, can walk around, and they also just get heavier. And so not as much fun to carry on your back all the time. One of the things we learned in some of our pilot work, which I'll briefly describe, is also that they're used as a blanket at night. And sometimes when the child is put down on the ground, if mom's going to go do something, they actually set them down on the blanket or on the wrap. So really in contact quite a bit of the day. So we did a pilot feasibility trial just to see, is this something that could work? And we did this back in 2019, really a small scale, as you can see, 50 participants. And we weren't really looking to see if this was going to make a big difference as far as malaria transmission goes. What we really wanted to understand is, what did moms think about it? How was the treatment process? Did the kids develop a bunch of rashes? And so this went reasonably well. There were no sort of hard stops, which is really all you can ask from a pilot feasibility trial. So we went forward with it. Really, this is what I was talking about. Really, no discontinuations. There was one rash, can't really make much of that, and no side effects. And people used them. Sorry. So we went forward and looked to do an appropriately powered trial. Basically, our hypothesis was that if the kids were carried in these, it would be a complementary, so an additional layer of protection against malaria when the child's outside the home. And that was really all we wanted to test. So some of these I've mentioned before, but it potentially could protect against outdoor biting. That's already used culturally. There's potentially a market demand, so this wouldn't necessarily have to be something that is issued through the government, right? Women are already buying these cloths in the market. It's the key age group. There's not a lot of skin absorption. One, the child wears clothing underneath this. They're not naked under there. And two, because it's bound to the textile itself, you don't get a lot of across the skin absorption and dermal absorption. And that's really been proven through military uniforms, which have been treated like this for decades. And again, it would complement some of the other tools that we already have. So how did we design our trial? So we used a one-to-one randomization, and we randomized dyads, which is the fancy term for a mom and a baby together. And we enrolled children starting from 6 months of age to 18 months of age. And that was the reason that was the age group, was that we wanted to make sure they would get at least 6 months of use out of it. We purchased the wraps locally. There was no difference in appearance. And then we either soaked the wraps in the permethrin solution, it's a 0.5% concentrate, or we just soaked it in plain water and re-soaked them in plain water as a sham treatment. And then blinding, the clinicians and people who actually determined whether or not someone had malaria were not aware of the randomization status. So again, an adult mom with a child with that age group, you, of course, no one would know where this is, but just the neighboring sub-counties of our study site. And then we excluded those with HIV and sickle cell disease, largely because they're supposed to be taking malaria prophylaxis already. Allergies to pyrethroids. So this is what it looks like when you actually soak the wraps. And some of you, if you're outdoor people, may have done this with clothing in the past. You can actually buy most of this stuff on Amazon. You can also buy spray application products, but this is one of our staff members treating some wraps. And so you can see the yellow bottles there are actually concentrate that we received from the manufacturer. We diluted that down to 0.5%. You get the wraps nice and wet and you put it in a Ziploc bag, wrap them tight, and let them sit for about 2 hours. And so, as I said, we did that, or we did it in water, just plain water for the control arm. And we also gave every new participating couple a new dyad, gave them a new bed net to make sure that differences in bed net access were not any cause of differences that we saw. Now, we did retreat them every month, and part of the reason for that, from the military and also from what you'll see from the manufacturer, if you were to buy this from Amazon, is that it probably lasts about 6 months. But we were uncertain about how local washing practices might impact the ability of the permethrin to stick. And so we actually retreated them every month. You could say that was probably overkill, but our question was, if you have adequate permethrin in the wrap, will it deter mosquito biting? Our question was not, how long does the permethrin in a wrap last, which is a future study now. So what did we measure? Our primary outcome was clinical malaria, which is a fever or reported fever and a positive malaria rapid diagnostic test. And we picked that because that's basically standard of care of what a malaria case is in a place like Uganda. If someone had that and they were treated, we then censored them from the analysis for about a month, and that accounts for reduced risk of infection following treatment, because the half-life of the treatment that is the standard of care in Uganda is probably around 2 weeks, maybe 3 weeks. So we wanted to make sure that we were not counting those as at risk when they had just received a course of treatment. And then we had a number of secondary outcomes. Of course, these we didn't power for these, but they were all there. And safety. So when it comes to this, I won't spend a lot of time. We made some estimates. We did think that the effect size would be what we cared about was a 30% relative reduction. We figured that if we saw at least a 30% reduction, this might be worth pursuing in the future. And so this gave us a sample size of about 400, 200 per arm. So now to actually get to the fun stuff. What did we find? So first of all, and this actually will get me teared up if I focus on it too much, but we were able to enroll very quickly and without a lot of screen failures. And the moms, I mean, just look at that attendance, greater than 99% of visits they returned for with no loss to follow-up. And I think that just reflects, I would say, two pieces. One is that we've built a great relationship with the community over many years, but also just the continued burden of malaria in these communities and how important an issue it is there. And so very touched that our participants, really made such an effort to be true members of the team. And so really do have to acknowledge the community. They did report high uses of BedNet. Of course, that's self-reported, not something we measured, but no reason to think that was not true, and certainly we didn't see any differences between the two arms. This is a standard thing, a protocol diagram. I would say we had no loss to follow-up, and 99% of the visits were attended. So not pretty well done on their part. So as you can see here, and again, really the main takeaway through some of this busy slide is that the two arms balanced out. Randomization worked for the most part. You can see that we were able to balance the age groups, the education of the moms, place of birth, all these things. Similarly, if you look at sort of the baseline clinical characteristics, there was only really 1 to 2 nets in each house when we enrolled them. You can see that the nutritional status was similar between the two. Hemoglobin levels were similar between the two at baseline. And we did a RDT at baseline, a test to make sure we didn't enroll anyone who was malaria positive. And you can see at the beginning that those were similar levels between the two at the home visit and then again at the clinic visit. So major takeaway is randomization worked. So what did we find? The major takeaway and what struck us when we went into data analysis is if you just look at the number of malaria cases over the period, you see that there were 94 in the sham treated group, the control arm, and 34 in the permethrin treated arm. And that was pretty astounding. When you look at the incidence based on the time at risk, you see that it's about 2 per 100 person weeks versus 0.73. Again, very large reduction. And that held when you look at the subgroups based on age. And the reason we split it out by age is that we thought children, younger children would probably be carried more, where children that are a little bit older at the time of enrollment may be walking independently more and carried less in the wrap. And maybe you could squint your eyes and see a little bit of a trend that would be consistent with that. I wouldn't make too much of it. I think the more important takeaway is that it worked in both age categories. So here's the time to event, cumulative incidence. Again, you don't need to be an epidemiologist to see the differences here. One thing to note is that there's not substantial differences, like it worked really well in the beginning, but not at the end. It seems a pretty consistent effect. And then for some of the secondary outcomes, this is really not something we had powered for, but I think is a natural conclusion that if you're going to have fewer malaria cases, then you're going to have fewer cases that progress to severe disease. And that's what we saw. So there were 17 malaria-related hospitalizations in the control arm and 7 in the intervention arm. And we didn't see any differences in hemoglobin levels, which I was a little surprised by, but probably given the 6-month time frame and the many factors that go into hemoglobin, including nutrition, there may have been some differences, or maybe why we didn't see a whole lot of differences. And then there was no change in the growth measures, which was a safety outcome measure to make sure that the pyrethroid was not impacting development. There were very few adverse events, and they were largely balanced. So what are the key takeaways from this? So quite obviously, permethrin-treated wraps worked, reduced the incidence of clinical malaria. We saw this effect even with high rates of, universal bed net access, because we gave them all new nets, and high reported use. And this really suggests that a lot of malaria transmission is being driven outdoors at these times that I talked about earlier. It's worked even in a region where resistance is really high. And this is probably because permethrin, in addition to being an insecticide, also has a repellent effect. It's probably not as strong a repellent as something like a DEET, but it does repel the mosquitoes. And again, if you think about it, you don't need perfect repellency. If you can get a mosquito to land and be like, I don't like this, and fly away without biting, or to interrupt biting before it's had enough time to penetrate the skin and take a full blood meal, that's enough, right? And so even though we had high resistance to the killing effect, this repellency may have been sufficient to drive the results that we saw. And then we didn't see any markers of concern around use for 6 months, recognizing these are planned to be used for about 2 years is what the full use for untreated RAPS is. So there's still some questions that came from this. So what is the mechanism? Quite frankly, I don't really care. It worked. I think it's important as we're thinking about, are there better ways to do this logistically is where it starts to become important. Are there other chemicals we can use? What about other applications besides soaking? Are they safe for the entire full 2 years? This is a really important question. We're getting some, I don't want to say pushback, but rather questions from end users around this, and it's something we're looking to identify in future studies. And like any intervention in medicine, there's a balance, right? So could there be a small effect? Maybe. I'm not going to rule that out, but will that be outweighed by the potential real possibility of death from malaria? There was just a paper that came out in JAMA from the group at Indiana that showed that severe malaria is associated with upwards of many years cognitive delays and neurodevelopmental impacts. So it has to be a balance question, risk and benefits. Does it work with the malaria vaccines? And then what are some other application strategies? This is basically outlining the next steps that we're taking with our research programs. There we go, good transition by me. So one of the things that we're working on right now is long-lasting wraps. So again, you can purchase if you go on Amazon, or there's a number of clothing lines, clothing that is treated in a factory with permethrin. And through different chemical processes, I've learned a lot about textile chemistries in the last few years that I never knew anything about. But they can basically impregnate the textiles with permethrin in a way that it's good for EPA approval is a year. But if you talk to the folks at some of these companies, they'll tell you it's basically the life of the fabric. And so what if you didn't have to retreat these? There's trade-offs that go with this, and these are things we're discussing. If you're going to give a factory-treated wrap, you have to decide on the textile and the color and the pattern before you put it into the factory. And so that suddenly directs your research towards consumer preferences that might vary from country to country or site to site. Not something I ever imagined myself getting into. Whereas if you were to soak it or have another point of care application, the mothers can bring the wraps that they've already bought in the market. But that trade-off in the opposite direction is that if mom brings her own, maybe it's 100% cotton that doesn't bind as well. And so these are the things that we're digging into right now. So just before I switch gears a little bit, some of the things that have happened since this publication. We have a project that will start next month, funded by the Thrasher Pediatric Research Fund that I think would be of interest to this group. We're going to do baby wraps in a refugee settlement, largely folks escaping some of the conflict in DRC. And the reason we're looking at this, because it seems obvious, you're like, well, if it worked in a regular community where people already have nets, why would it not work in the refugee community? And so some of the questions are actually very much about risk and thinking about the life or the transition period for some of these displaced individuals. So right now, with humanitarian funding in decline, a lot of the refugees who come into these new settlements, when they first arrive, don't receive any shelter. They get a plot of land, and they're told to basically build their own shelter out of sticks, and maybe they'll get some tarping. But if you don't have shelter immediately, you can't hang a bed net. Um, or maybe you've seen some of this work by S.C. Johnson with these spatial emanators. You can't hang a spatial emanator. And so our hypothesis there is that if we can treat the RAPs, because 80% of the refugees coming in from DRC are women and children. If upon arrival and registration, we can treat the RAPs or provide them with a factory treated RAP, will that give the mother and child 6 months or maybe longer to have malaria be less of a concern? And so they can get settled, they can build that shelter, get established, find their way into the clinics, things like that. So that's one of the key issues that we're thinking about. Something that's very interesting to me, a little harder to measure, is if this is really a repellency effect, then does the young child having a RAP also protect older brother, older sister who are nearby? And so that's something we're looking at as well, because then you've basically got like a mobile spatial emanator that travels with the family in the settlement. So that's a study that should be, the funding should arrive next month. We have our new R01 from the NIH, which still exists, believe it or not, but we are going to be doing factory treated RAPs for the full period. So we'll be following those children and mothers for 2 years and then an additional year afterwards to see if there's any rebound effect after they come out of the RAPs. That trial is going to be done across a number of sites, some of which are getting malaria vaccine. So the malaria vaccine starts to be given around 6 months of age. You get a monthly dose, 6, 7, 8, and then you're supposed to get a booster about a year later. So you thinking about RAPs, if they start to be used around 2 to 3 months and given up around 2 years, it's almost like a bridge while a child is able to get vaccinated. And so understanding how those two interventions interact is really important. Now, that's what we're doing with RAPs, but it's not just limited to that. So you can think about school uniforms. So who are the next sort of, if we were to expand this general concept, school-age children would be the next high burden group that I would think about. They're still vulnerable to severe malaria. And school uniforms are a really neat target because if you have kids, you know that you replace their school clothes every year, if not sooner, because they grow. So, and in a place like Uganda, each child really has one, maybe two sets of uniforms that they wear to school, and they wear it every day. And in fact, it's often their only clothes they have for the rest of the day. So if you could get a school uniform treated and it only needed to last a year, that has real potential. And so again, school uniforms are already used. Families often have to purchase them as part of their school fees for the year. And so we're not doing behavior change again. And maybe there's market principles that could make this work outside of sort of the traditional aid or government distribution programs. I think maternity clothing is another one. Maybe a little more difficult, but we'll see. Something we're interested in, but I think school uniforms is sort of the next part. So I'm going to pause there, or at least change directions for the last part here. I'll just say that I am someone who never thought I would publish anything in the New England Journal of Medicine. I started working in Western Uganda 13 years ago, this month actually. And I was drawn to the site where we work because I thought we had the potential to do work that would be incredibly meaningful in the community, that there was a chance to make a local impact. And it's a small site. It's way outside the city, not the type of place where you ever thought you might be doing the type of trials that would be published in the New England Journal of Medicine. So that has been a real moment of pride. The idea that we've gone from, there's three outpatient clinic room, four examination rooms, and there's about a 20-bed ward, inpatient ward, to that being a site for a trial that was published in the New England Journal of Medicine. So a lot of pride, a lot of ability or time to kind of think back on where we started and where we came from. And with that, to all the trainees and junior faculty out there, I would say, you're hearing me talk at grand rounds at a moment like this, and it's easy to get the perception that this is what success looks like in research. You have the wind at your back, you're cutting through the waves, all is going well. Imagine, me standing at the helm, pointing in the next direction. But in reality, a lot of what research is looks a lot more like this. You're on a lifeboat, things have gone terribly, you're just trying to stay alive, right? And so I have tried my best because I think we in the research community, especially as mentors, talk too little about our failures and when things don't go right. Because in a lot of ways, research often looks like social media. People post their best selves at certain times, and the universities point out and highlight when we've had success. I mean, I don't think UNC has ever been like, Ross Boyce applied for an R01 and didn't get discussed in study section. They don't put that in the newsletter, even though that happens 9 times out of 10 applications I submit. And so it's great. You have to take the moments of success and savor it. And so this was one of my reviews that I received at the New England Journal. And I actually have printed this out and keep it in my office to remember and keep this in mind as to why I do this type of work. Like, that's a moment. But at the same time, we had actually, I think it's really important to point out that we had submitted this to another journal before, and I want to show you some of the reviews that we got. So this was one of the reviews, which is no different than our protocol paper. What? How is it not any different than our protocol paper when we actually have the results? But this is the type of stuff that you have to get used to. Here's another one. Someone accused us of being unethical for not giving the newest version of the bed nets out. Well, the newest version of the bed nets weren't available when we started our study. And this one pointed out the cost of permethrin based on the price at Amazon, which is just ridiculous. I mean, the price of what it cost for us to treat each one of those was probably around 30 cents. And of course, we're not going to be buying bottles of spray application at Amazon. But it just goes to show you, sometimes it's just luck as to who your reviewers are, how they read it, the timing of what's going on with a journal, whether or not it even gets sent to review. And this is true just not for publishing, it's true for grant applications. And so I love what I do. I think I have a great job. I get to work in a country, Uganda, where I have fantastic partners. I think we do work that makes a difference. I have a lot of freedom in my position here at the university. I met my wife in Uganda. I like to joke that she's from Texas, and I think if she was Ugandan, we'd probably have fewer cultural differences. But it's I have a lot of ties to the community, and really, I love the creative aspects of what I get to do as a researcher. I get to see problems, think about how we can solve them, and test them. I mean, like, that's great. And so again, people will tell you things You'll get feedback. Medicine is a tough career. As a med student, you're told don't know anything. As an intern, you're told you don't know anything. As a researcher, you'll get told your ideas aren't worthwhile. Someone told me at some point that our site would never be an amount to anything, and I should work at the big city hospital in Uganda. So keep true to the things that uplift you. We took my kids to Uganda for the first time last year. It was somewhat like the research pictures I described of high highs and low lows. It's a long trip for them. But having them see the work we do, watching them play soccer with the kids in the village, having to stop on the road out to the village because an elephant had crossed our path, not in the park, just crossed our path. I mean, and perhaps more importantly, they got to see the work that my wife and I do and understand why sometimes we're gone. So that was really amazing. At the same time, this as our paper was published and we were having our sort of evening moments at dinner and talking about what we were grateful for that day, I mentioned that our paper was just published and we celebrated it. And my son responded with a comment on my meatballs that I had made for the family that night. So keep it all in perspective. Do what you're passionate about. And thank you for having me today. And if you have any questions, I'm happy to take them. So thanks.
Dr. Boyce, thank you very much for sharing that very personal and inspiring story from start to finish. I think one of the things that I would also point out for many of the learners and even the old timers in the audience is that your focus, your singular focus, has really been, I think, an advantage, that you didn't get sidetracked looking at different things. And clearly, for NIH success and success in science, that is singularly probably the most important, the tenacity of sticking to the particular problem at hand. But having said that, and at the risk of you telling me you don't care, let me ask you, because I can hear you saying that, let me ask you in terms of generalizability of this approach to other arthropod-borne diseases, and whether you can envision, maybe not, you're not interested in it personally because you've got so much to do with malaria, but are there opportunities for looking at geographic specific types of apparel or diapers or something that would be very much important for controlling Zika or other types of conditions?
Yes, well, thanks for that. I would say theoretically, it should be mosquito agnostic, right? It should work for Aedes mosquitoes, should work for Culex mosquitoes. And for malaria, we've done some initial exploratory work, and I would say across from West Central and East Africa, wraps of a similar type are used. So I think that piece I feel good about the generalizability. In South Africa or Southern Africa, I recently met someone who told me the wraps are thicker, more like a towel type material. So that could be a little more challenging as far as the textile chemistry goes. We have started some conversations, and I actually sent an MPH student to Thailand just this week to start thinking about the Thai-Myanmar border areas where you've got not only malaria that persists, but dengue is a real problem. And so one of the things we've learned there is that there's something akin to a wrap. It may be a little different. It's maybe a thinner material, and it may not be used for such a long period of time. There's some cultural reasons for that, but it's still enough there to say, well, could we have a small malaria or a small cultural adaptation to what they're already doing? The next step, I think, is something like one that comes to mind for me is Chagas disease. And so what about a blanket for Chagas disease, where you have a nighttime biting bug, or even a sheet, right? Because I know a lot of those areas are warm. So I think about that one. So there's a lot of potential. Again, it's not all areas that I will end up pursuing. We are trying to sort of, for lack of a better term, franchise or help people who want to pursue some of this work. Some of the funders are very interested in this work and the manufacturers. So I do think there's potential, and I'm excited to see where it goes.
So are we. Thank you very much, Dr. Boyce. Well, I want to thank you and Dr. Gregg, of course, for inviting you today, and remind everybody to check the chat for the link for CME and MOC. I look forward to seeing everybody next week, and please take care of yourselves and each other, and hopefully we'll meet again next week. Thank you.
Thanks so much.
Be well, Dr. Boyce.